Welcome to the Accommodating Workers with Mental Health Disorders from Research to Practice webinar. This is the 5th webinar in our Return to Work, Stay at Work series, and we're very glad you're here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is made possible through the support of the Direct Access Program through the BC government. And as I mentioned, my name is Tanya, and I'm moderating the event today. And our presenter today is Dr. Izabela Schultz. Dr. Schultz is a registered psychologist specializing in medico-legal and occupational aspects of psychological, neuropsychological, and pain-related disability, both in her academic research and in her forensic practice. She currently is a professor in the counseling psychology program at the University of British Columbia, where she also serves as the director of the only Canadian graduate program in vocational rehabilitation counseling. Her innovative investigation into the prediction of pain-related occupational disability has won her research team 2 international research awards. So I will go ahead and hand it over to her now. Thank you.
Thank you. Good morning. I would like to welcome you to the presentation. And what I wanted to do is tell you a little bit as to how I became interested in accommodating workers with mental health disorders. When I was working as a clinician with clients, particularly injured workers who were difficult to accommodate and difficult to return to work, I worked very hard with the worker on a variety of mental health issues he had. However, I at some point decided to phone the employer and find out what the situation is with the return to work planning. And here's the answer I heard from the employer. I would rather go bankrupt than accept this worker back at work. And this particular statement I found quite stunning. And the more I researched the topic, the more I read about it, the more clinical practice I acquired, the more I understood how challenging the process of accommodating workers with mental health disorders is for employers, for human resource professionals, for clinicians, for doctors, for psychologists, for occupational therapists, for case managers, for insurance adjusters, and for anybody who is a stakeholder in the return to work process. This is a very, very complex process. So what I wanted to do is share with you some of the knowledge that I gained through mainly my research in the area of accommodating workers with mental disorders, to tell you how mental disorders affect functional performance in the workplace, what strategies, techniques, and approaches have been empirically or evidence in a supported way found to be helpful in returning to work or transitioning to employment for those individuals who actually do not have any stable work history. What I wanted to start with is a concern about what we see as a disability epidemic in the workplace. The statistics in all industrialized countries show that there's growing absenteeism and long-term disability rates and costs across a wide spectrum of disabilities, but specifically related to mental health conditions. Productivity is also a problem. I don't know how many of you are familiar with the term presenteeism, which has become quite fashionable in the last half a decade or so. That means inability to work to full capacity while being at work, with a typical example of a person with significant anxiety problem who is working in the office, looks at the computer, is doing something on this computer, but is actually not very productive due to concentration difficulties, inability to focus on work, or making some errors in data transcription. What we are also noticing is premature terminations and turnover. People who perhaps would be able to work with accommodations and with appropriate interventions are unable to work and they quit by themselves, or they are encouraged to quit, or they actually terminated. So an unresolved problem of mental health disability creates an issue around the turnover in the workplace, which can be very costly. The costs are also quite a significant factor. Increased healthcare, insurance, and case management costs for occupational disability have been noted worldwide. So if you ever want more statistics on it, they are quite frightening with respect to the impact on economy, not only on individual human suffering, on bottom line of employers, but overall. Because when you're looking at the 0.5, what we are seeing is contribution of work disability costs to gross national product is on the rise. And for industrialized countries, it's now climbing over 7% mark, meaning 7% of our gross national product is actually going to serve the cost of disability in many different formats. More statistics. About 7% of all Canadian workers had absentee days that are attributed to mental and emotional problems. That's a very significant statistic. What we also need to admit is that many people who have mental and emotional problems phone in sick, claiming that they have a physical or somatic problem when in fact they have a mental or emotional problems that masquerades itself as a somatic problem because a somatic problem is more socially acceptable. You know, very few people would actually phone the employer and say, hello, I am just phoning you that I cannot work due to depression or due to my severe panic attack I had this morning. I think these numbers, the 7%, is probably actually much higher given social stigma associated with reporting inability to work due to mental health problems. 50% of those who miss work due to mental or emotional problems will take either 13 or more days off or will never return to their jobs. So look at how much of a high-risk situation we are facing here. So people who start taking days off due to mental health problems are very high risk of actually ending up with occupational disability. Workplace absenteeism due to mental health conditions accounts for about 7.1% of the total payroll, and I would like to emphasize the same reservation as I had with the first 7% statistic, that we probably don't even know how many more workers have truly mental health conditions, but they phone in with some other explanations for their absence. In Ontario, during a 30-day period, about 8.4% of the working population experiences a mental health condition without a physical disorder. So these statistics are quite sobering. Talking about presenteeism, typically, the statistics on presenteeism indicate that people with mental health problems lose about 4 hours of work a week in terms of productivity. They are physically present at work, they may be sitting at the desk, they may be listening, or they may appear to be listening to what's going on in the meeting, but they are actually not productive. Their mind is somewhere else, they have difficulties focusing, and they may be experiencing intrusive symptoms such as anxiety or depression. And absenteeism due to mental health conditions amounts to about loss of 1 hour of work a week. Yeah, as you can see, these statistics are from about 2000 to 2003, and by watching the epidemiological trends in mental health disability, they are probably higher by now. Why is it happening? What's going on with mental health disorders? Why they have become so preeminent? The statistics show that the prevalence is increasing and it may be associated with earlier onset of mental disorders. About 2 to 3 decades ago, it was unheard of that a child may have depression. Now childhood depression is a commonly recognized condition. Children and youth with problems around depression or anxiety grow up very often to become adults with depression, anxiety, and they join the workforce and they struggle because of their issues. We also know that the complexity of life in general and work demands is increasing, which makes it difficult for people who may have emotional limitations or cognitive limitations related to work. What we also find is that there are fewer natural support systems in society. Our society is becoming not really much more integrated, it's actually becoming more fragmented. We have healthcare that does not always work very well for people with mental health disorders, and people are moving a lot, which means that they can no longer rely on their community and other sources of traditional support, not even mentioning some difficult issues going on in contemporary family. So that's one of the factors. Then with respect to our knowledge base is really founded upon quite limited research on transition to employment, employment retention among young people, and job accommodation. And unfortunately, also our existing knowledge base is rooted in biomedical model. When you look at research on depression, anxiety, serious mental illness, addictions, and other mental health conditions, we'll see that most of the research is psychiatric in terms of the questions being asked and design of research. So the studies are on which medications are best for which conditions, which psychotherapies are best for which conditions, but there is much less research on what would be the best employment integration approaches or best accommodations in the field, although this new research is just developing at this time. And then we have an issue of bias. We have societal and employers' biases against people with mental health disabilities. There's what we call negative halo effect. If you happen to be an employer or a human resource professional or a case manager and you just supposed to interview or meet with an individual and you know they have a history of mental health conditions, you may encounter some biases. You may be thinking that they're somehow intellectually slower, or that they may have emotional problems, or worse of all, they may not get along with other coworkers, or they may become confrontational or difficult with the supervisor. And I'm not suggesting that specifically the listeners to this presentation would have these attitudes, because you're the selected few who actually were interested in joining in and listening on the topic. So why would mental health disabilities be a challenge to employers? Well, as we all know, we need a talent pool in the workplace, and at the same time, we are dealing with a high prevalence of people with mental health disorders. So because of the high prevalence of mental health disorders, no economy and no employer can really afford not to employ them. We employ them whether we know about their mental health disorders or we don't, or people may develop mental health disorders in the course of employment, because of employment or because of many other issues that may be going on in their lives. The challenge around mental health disabilities also involves the fact that they are very often chronic. Having, for example, a history of a significant episode of depression increases the likelihood of future development of depression. So they unfortunately tend to become chronic or recurrent, particularly if medical treatment and a psychosocial treatment is not in place and they are not accommodated, and at the same time their symptoms are aggravated by stress. Yet our contemporary workforce cannot really function in the environment where stress does not exist, because stress occupational stress inherent in our workplaces. In clinical practice, we are always looking for so-called low-stress employment settings, and they are extremely difficult to find. So if any of you in the audience happen to be knowledgeable of any low-stress employment places, I would be really happy to hear about them because we always look for them. Many positions and many people require job accommodations in order to function appropriately, yet negative social attitudes still are present towards people with mental health conditions, and I'll tell you in a moment a little bit more about them. There's confusion about resources which are needed and available and about proactive practices, and sometimes we simply may be lacking some skills to work with people who have significant mental health conditions. They may not always be the easiest people to work with. They may not be the easiest claimants. They may not be the easiest employees or clients to accommodate because of a variety of issues that they are facing, and they may have a history of some negative experiences with the healthcare system or with the workforce. So just some more specific statistics around prevalence of mental disorders. Another sobering statistic from the World Health Organization: mental disorders comprise 4 of the 10 leading individual causes of disability worldwide. They account for about 10% of the global burden of illness, and importantly, it is anticipated that by 2020, depression is likely to become the most prevalent disabling condition in the hierarchy of medical problems that people may experience, and exceed cardiovascular and respiratory problems. Depression at this time is the second highest burden of disease and is anticipated to become number 1. So if we're hoping that we can wait out this wave of depression, anxiety, and mental health problems in the workplace, we are unlikely to be able to do so. These disorders are here to stay unless we have a concerted effort as a society and as employers and as clinicians to address this issue from a variety of perspectives at the level we can address them. So the presence of mental disorder, any kind of mental disorder, translates into an average of 1 day work absence and 3 days of work cutback per month. So those of you who are into economic aspects of workplace functioning can translate it into the costs to employer. Mood disorders, for mood disorders such as depression, we are looking at 6 cutback days, and for anxiety disorders, 4.5 cutback days. We have a little bit fewer of cutback days for anxiety disorders, and this is because people with anxiety disorders actually often come to work but they have difficulties with productivity. While people with mood disorders, when their depression is really severe, they simply cannot get out of bed and they cannot come to work, so therefore they have more cutback days. What are some of the most frequent work disabilities? They include what is called dysthymia, or mild, very chronic type of depression that goes on for years, major depressive disorder, post-traumatic stress disorder, panic disorder, and social phobia. And what was found in large epidemiological studies in the United States was that the presence of mental disorder reduces probability of employment by 11%. That's a very significant finding. The social stigma issue is particularly a potent issue with respect to mental health disorders. People who have cancer, pneumonia, brain tumor, or any other medical condition typically do not face social stigma. Yet people with mental health disability, despite positive changes in the society's outlook on these conditions, still is a problematic issue. So social stigma often is based on some workplace myths which perpetuate employers' attitudes, which some may call discriminatory. What was found in a research in 1991, and I certainly do hope that current research would show more positive findings, was that 90% of employers would hire a person with physical disability, and as a matter of fact, many employers are looking for people with physical disabilities. I had some conversations from colleagues from a BC Paraplegic Society, and they're telling me that employers often found them looking for people with paraplegia and who use a wheelchair for mobility. But I never heard from anybody phoning BC Mental Health Association looking for an employee with a mental health disability, although I may be incorrect, and please correct me if I'm wrong. Yet only 20% of employers would hire a person with mental illness or mental health disorder. There was this interesting study done in 2002 which showed that employer attitudes towards persons with mental health disabilities improved with previous positive experience in working with persons with mental health problems, being part of the government sector. Interestingly enough, being a female employer predisposed employers to be more positive towards people with mental health disabilities. Higher level of education of the employer or supervisor would imply better more positive attitudes, and also a provision of on-site training from a supportive agency. So I think these are important findings, and they underscored the issue around awareness raising and on-site training. What is an accommodation? As you probably all know, it's a modification or adjustment to a job, the work environment, or the way things usually are done, work strategies that enables a qualified individual with a disability to enjoy an equal employment opportunity. If you're ever looking for helpful practical information around job accommodation, there is this job accommodation network out of University of West Virginia, provides very excellent online resources for employers and other people. So what are some examples of accommodations for employees with mental health disabilities? Flexible scheduling is one of them, including part-time work or job sharing, flexible hours of work, provision of flexible breaks, flexible time off, modified non-essential duties. So flexibility is a huge theme in accommodation of people with mental health disabilities. Changes to physical environment, such as reduced distractions with room dividers or partitions. As we know, we are into the world of partitioning in the workplace, and very few people have their own single office with full walls and doors. This actually makes it difficult for people who have problems focusing, who are anxious, or who are depressed. The use of white noise or soundproofing is important because that blocks some of the distractions, sound type of distractions. If people are working in a more common work environment, those with mental health problems really appreciate the access to some personal space, at least for part of the day, some rest area, and water. Social environment, communication, training are also critical. Coworker support and mentoring. I have to, this moment, just cite one example from my clinical work. I was working very hard as a clinician with a client who had a history of significant depression and anxiety. Together with the vocational rehabilitation professional, we worked very hard, developed a return to work program, and everything looked great on the paper. The client is showing up. The client works in the cubicle sort of designed, oriented work environment and finds out that she is alone in her cubicle because her coworker who used to sit next to her now moved away to a completely different part of the room in order to actually not to have interactions with her. So immediately she developed a lot of anxiety. She felt unsupported, rejected, ostracized, and we have more problems than we started with just based on lack of coworker support and even their physical absence from mentoring or supporting her. Job coaching is another strategy, positive supervision approach. As a matter of fact, a positive supervision approach is not something that is unique to people with mental health disorders. It is considered to be just a good practice for any employees. On the job training and extended orientation, there may be more work that needs to be done up front. Some clients may become easily overwhelmed and overloaded by what they hear during the orientation. They may need some written instructions, or they may need to have the orientation information divided into smaller portions so they can actually process this better. They also need a regular performance feedback, but the frequency of this performance feedback often depends on the person. So we don't want to underdo it or overdo it. Best to ask the employee how often they would like to get their feedback. Many of them would say, oh, I really would like to get it daily, and some would say, no, thank you, I know my job, maybe we could just touch base once a week. So that may be different for different people. And there are also, of course, assistive technologies, different computer, hardware and software modifications, color coding of different materials, note-taking systems, organizational aids, timers and alarms, spell checkers, and glare guards for computers. For people with comorbid or additional pain problems, we may need some ergonomic arrangements as well. However, our topic today is not specific to chronic pain. The cost of accommodations, many employers fear that the cost of accommodation is very high, but Granger, Barron, and Robinson quite a while ago looked at the cost of them and found that initial costs were none for 58% of people with mental health disorders. Ongoing costs were also none for 54%, and supervisory costs were none 15%. But high costs only for about 10% of people. The high costs are defined probably over something like $500 or whatever it might be. Many costs are actually social or interactional, just interacting differently, talking differently, using different style of communication. That really doesn't cost anything in terms of money. It just costs a little bit in terms of a skill you apply and a willingness to apply certain skills that may be more effective. These are some of the results of the study we completed in 2010. This was a study sponsored by the federal government in Canada, Human Resources. We surveyed 80 randomly selected employers across Canada about the types of concerns they have with respect to people with mental health problems. We found that over 50% of employers we surveyed had significant concerns, and most significant concerns included concerns about bizarre behavior, maintaining mental stability, employee becoming violent in the workplace, very high statistics, an ability to tolerate work stress, and ability to tolerate working conditions. So Canadian employers are very concerned about people with mental health conditions. Yet when I look at some of the top concerns such as bizarre behavior and becoming violent, these are extremely low incident types of situations, typically made famous through some media accounts of someone in the United States typically going postal, quote-unquote, and shooting a hated supervisor or hated coworkers or someone who got fired and then resented being fired and developed significant violence problems. There may be some people who have a history of serious mental illness that's not properly controlled by medication as well. But when you look at the most prevalent conditions such as depression and anxiety, people with depression and anxiety never become bizarre or they never become violent. Yes, they might have difficulties tolerating work stress, but they can be accommodated as well, and particularly if they have ongoing treatment going on. This is just a breakdown of industries we looked at in our survey. As you can see, our survey is based a lot on service industry, public administration, wholesale, and transportation. We had a lot of difficulties accessing information from the agriculture industry and from construction and finance as well, for whatever reason. Some employers were also claiming that they never seen a person with mental health disability in the workplace and they don't know what accommodation is, you know, we should not be really phoning them because that's not their problem. And unfortunately, it's now everybody's problem, and even if employers have not thought they've seen people with mental health conditions, these people are there in the workforce, and we can almost guarantee it. What were the most significant predictors of job accommodation by the employer? Industry category, as we just talked, size of the company, and the larger the company, the more opportunities for accommodation were there because of more resources being available. Perception of the worker personality was important. If the worker was perceived as having good stamina and good attendance, what we would term having a good work ethic, they would actually get more accommodations. And worker performance was important. If the worker was perceived as organized, the employer was much more willing to provide accommodations. So we thought that was an interesting finding as well. So what were the conclusions from our study? We found that these main concerns of employers included bizarre behavior, violence, mental stability, stress tolerance. We also found that employers' knowledge of accommodations, which we also surveyed, was very fragmented and limited. Employers were familiar with basic communication and interaction-oriented job accommodations, but they were very unfamiliar with structural, environmental, and organizational underpinnings of job accommodations. The size of the company, the existence of written policy on hiring people with disabilities, and past experience in hiring persons with disabilities predicted awareness of accommodations. So obviously with more work that we can do, we are getting better results. So what are some of the employer-level interventions we should be aware of with respect to accommodations? Primary prevention involves organized restructuring, building what we would call healthy workplaces, developing written policies on health and wellness. Many large employers are, to a very significant degree, interested in developing policies and practices on health and wellness. I can alert you to a new book that we just co-edited with the colleague, Dr. Robert Gatchell, called Handbook of Occupational Health and Wellness by Springer. So if you're interested in developing new policies on health and wellness, you will find wealth of information. This book just came out this month, and I actually have not even seen a hard copy, but I noticed that it's available. The budgeting for costs of accommodation is important. If these costs of accommodation are unbudgeted, then it becomes a goodwill of a particular manager or supervisor. And in intelligent and productive workplaces, we do not want to necessarily solely rely on goodwill. We want to have proper budgeting going on. And what's also important is appropriate training of management and supervisors. As I was saying, it's not that difficult to accommodate people with mental health disabilities, but you need to know certain approaches and strategies that can be learned. So now looking at reduction of disability. Now that we already have an employee who has a disability or someone who is off work and needs to return to employment, how do we go about helping this person return to employment and maintain employment? Because very often people return to employment but they're unable to keep it, they become stressed out, and they give up, or the employer gives up on them, whatever happens faster. So disability management is one of the strategies. I want to invite you to read a chapter by Dr. Henry Harder and his colleagues in the book I co-edited with a colleague from University of Boston entitled Work Accommodation and Retention in Mental Health. This particular chapter is specific to disability management in mental health. And I will have the entire title of this book at the end of the presentation, so you don't need to rush to write it down right now. It's probably very helpful for your purposes. Supported employment is another way of reducing disability, and supported employment applies to people who have most severe forms of mental health illness, and that's people with severe forms of schizophrenia, severe bipolar disorder, the type of bipolar disorder that requires frequent hospitalizations, and also people with brain-related, severe brain-related disorders may require supported employment. Job employee matching, there may be many jobs that the individual is capable of performing, but it may not be the one that they currently have. Recognizing and targeting barriers to job accommodation, and then applying job accommodations. In our study that was sponsored by the federal government, we interviewed 40 vocational experts, both clinicians and researchers, about which work accommodations they consider to be most important for people with mental health disorders. And we also reviewed hundreds of studies that have been done in the field to discern which work accommodations have the best evidentiary support. And these 5 types of accommodations, among many of the types of accommodations that exist, have the best evidence support. Modified work duties, flexible scheduling, modified work environment, job sharing, and assistive technologies. All of them require flexibility, ability to modify, and ability to problem solve together with the client or the employee, and being able to come up with solutions in the workplace that are going to promote this person's return to work and ability to retain employment. In addition, there are also a number of employee-level interventions, more clinically oriented or vocationally oriented interventions with an individual worker. And that involves early identification, diagnosis, and treatment. You may recall that now we have these depression screening days and awareness raising days with respect to mental health. All this serves the purpose of ability to identify these problems early, diagnose them, and treat them both medically and psychosocially, particularly through psychological treatment. With respect to what we can do in the workplace, we need to understand what the employees' functional limitations are, which means that we need a worker-centered assessment and planning. The workers often benefit from a coping skills training, which could be provided by clinicians, or it could actually be even organized in some large workplaces if they have enough resources to do so. Personally, they benefit from self-awareness counseling, so they understand what their strengths and limitations are and how they can cope with the workplace. They, of course, benefit from social network development. And there is now an approach involving work hardening or work conditioning, exposure to the workplace, not just for people with physical or pain conditions, but also for people with mental health problems, using the more of a graduated type of approach. And of course, job coaching always comes up as a helpful strategy. So what are some of the best workplace-based practices? In a nutshell, conduct assessments focusing not on diagnosis, of course. Employers really don't need to actually specifically know whether it's depression or anxiety. The employers need to know what are the functional limitations. Is the person able to concentrate? Is the person able to do accuracy or oriented task? Is the person able to make decisions at the level that they make? Is this person able to interact with customers in difficult and conflicting situations? They need to know all these functional limitations, but not necessarily diagnosis. Offer training, enhance social support, particularly coworker support. In this difficult case that I mentioned to you where we're returning a client to work and the coworkers moved away with their cubicles, what we've done is assign one coworker who was, I would say, less unwilling to support this particular client to become a resource person for the client. Meaning a person who can help with procedures and policies or practices whenever the person who returns to employment gets stuck and cannot move forward, would be the person to go to. And interestingly enough, as the process went on, the resource person herself changed her attitude towards a person returning from work quite significantly, which really facilitated the process. Then promoting flexibility with respect to scheduling and assignments. I know it's sometimes a major headache for the employer who has different job descriptions very structured and schedules very structured to allow that flexibility. But unfortunately, this turns out to be one of the most appropriate and effective strategies. So perhaps the upfront cost of being flexible then is returned by the person's increased productivity. If this is a difficult return to work scenario, using an employment specialist such as vocational rehabilitation consultant, occupational therapist, or a human resource specialist who has special training in the field. Using multidisciplinary resources, reaching out and checking with the psychologist or doctor or any other professional working with this individual while protecting privacy and confidentiality. This is a very sensitive issue, why these particular employees are getting these accommodations, and very often they don't want their coworkers to actually know. When I work with individuals with these problems, they often say, well, I don't know what to say on my first day back. I don't know whether I should be disclosing or not disclosing. What should I say? And that very much depends on this person's relationships in the workplace and degree to which this person can be accepted by others upon return. And providing performance evaluations and feedback. The functional limitations are divided into cognitive, social, and emotional. And what I wanted to show is just give you an example of a table that was developed by Dr. J. Wald, W-A-L-D, in a chapter on anxiety disorders and workplace accommodations. In the book, I co-edited with Dr. Rogers from University of Boston. This is specific to anxiety, but this is actually quite a unique example of how well you can link possible functional limitations of an individual with an anxiety condition to suggested work accommodations. I don't want to go through every single bullet here, but I wanted to show you that some dimensions of work performance targeted here are interpersonal, emotional, and physical. Functional limitations under interpersonal may include difficulty communicating, interacting, and socializing with supervisors, coworkers, and general public, difficulty handling criticism and feedback, difficulty with anger, irritability, difficulty working around other people, working with supervisors, requesting assistance, or disclosing limitations. And what you have on the right side of the table are ideas that you could utilize, such as having natural supports, a buddy system, a coach who is helpful, education, structured system of feedback, having very concrete expectations presented in a friendly rather than pressuring way, because of course social stress would cause deterioration in this person's performance, regular scheduled meeting with supervisors, having written goals and expectations, and modified supervisory style, for example, provision of support and reinforcement, using other communication media such as email or phone, although there are a lot of individual differences. Many clients who have anxiety problems I work with, they say they're actually afraid of phone calls from their employer if they're off work. And in one case, I can recall we spent an hour in a valuable session time debriefing a phone call from an employer. So it may work positively, but it may also work negatively depending on the circumstances and the communication style used in that phone call. These are some of the suggestions for accommodations for attendance, productivity, time management, and for cognitive issues. So you're very welcome to go over it, and the entire chapter is in the book I just mentioned. The best practices are also contained in the book. Modifications to job description, including changing the way the tasks are scheduled, flexibility or part-time scheduling. Flexibility was found to be effective for all functional limitations. Changes to the workplace environment which reduce auditory and visual distractions, quiet environments, or having some sound blocking devices and not too much visual stimulation, job sharing, assistive devices, utilization of coworkers and supervisors and mentors, and behavioral interventions such as regular meetings to provide feedback. Future research. What we anticipate is that there will be more research, and the research will be more transdisciplinary and will use multi-system approach, including multiple stakeholders, workplace staff, employers, healthcare people, and others, not just people with mental health problems. We need to move away from just purely a pathology and diagnosis world into the world of functional limitations. We need to look at diagnoses that are perhaps not as prevalent as depression, because most of the research is on depression and anxiety, very little actually on addictions, although our new upcoming book, Handbook of Return to Work, will have a chapter on return to work for people with addictions, which is quite unique. Predictors of work disability need to be researched. We need to learn how to perform functional assessment not only for physical issues but also for mental health issues. We need to learn more about organizational interventions and learn how effective which accommodations specifically are. And last but not least, we need to listen to the voice of the consumer, listen to people who have mental health conditions and other non-visible conditions such as pain, which can often be associated with some symptoms of depression and anxiety as well as a result of having chronic pain. We need to listen to people about what would help them in the workplace and which accommodations they can appreciate and which ones they would not. This is an appendix. It just shows you some of the research studies that were done in the field. If you are actually looking for references, there will be more of them in the book. These are studies done internationally in the United States and France and Netherlands. Netherlands is actually a research powerhouse in terms of work accommodation and occupational health. I would also refer you to the Job Accommodation Network and to the book we published, Work Accommodation, Retention, Mental Health, with Dr. Sally Rogers, which has specific information on variety of mental health conditions and work accommodations that work best for these conditions. And in addition, I already mentioned the new book we published on occupational health and wellness, which can help with primary prevention issues. So I can see that we probably have about 20 minutes of time to go over some of the questions which you probably have been sending all along. So I will be now waiting for these questions to appear in front of me. Thank you very much for your patience. I hope I wasn't speaking too fast.
Wonderful. Thank you very much, Izabela. So far, we actually don't have a ton of questions that have been asked thus far, which means your presentation must have been very clear. But if you do have questions at this point, feel free to type them in, everyone. One of the ones that has been submitted was, could you please comment on clinician skills with regard to providing specific psychological functional impairments and appropriate accommodations for a particular client?
Thank you very much for this question. This is actually a very good question, but at the same time a difficult question, because I am quite aware that many psychologists are trained in the what we call psychopathology model. They focus on the diagnosis and on making person free of symptoms. And this is very appropriate, of course. People suffer, they need to get better. However, at the same time, they often forget about the importance of understanding functional limitations that people have and barriers to return to work. Many psychologists are not specifically trained in understanding how work is impacted by mental health disorders. We need to do a lot of training and education, and I've been actually personally doing quite a bit of that kind of training. In March, I will be having a seminar at UBC on mental health disorders and work, but there's still not enough being done in terms of training clinicians. Remember, our graduate schools, which produce future psychologists, do not really have a course on mental health and workplace functioning. So we need to demand the skill from our psychologists, and if the psychologist is unwilling or unable to provide service with respect to support of the return to work process, obviously we need to find another psychologist who perhaps would be more helpful. It is my understanding that, for example, WorkSafe DC has a large network of registered psychologists who are willing and have skills and training to provide psychological treatment and counseling with the return to work and vocational and functional component, which means that psychologists are gradually moving into this field, but it is still a problematic issue. And what my suggestion would be, if you ever encounter this problem, team meetings are extremely helpful. What we want to avoid is development of us versus them approach when we are working with the client with a mental health disorder. What I've seen in practice is sometimes a psychologist working very diligently with the client who is expected to return to work on a variety of issues. They develop an outstanding rapport. And at this moment, there is no team meeting, there is no prior warning, or perhaps the prior warning was not heard as clearly as it comes out now. The client now receives a letter in the mail or some other sudden communication that they have a deadline by which they need to return to work. And although I understand why these letters are sent and these phone calls are made and how they coincide with a variety of policies different companies have, but it can absolutely ruin the work that's done by a clinician as well, because now instead of dealing with real return to work barriers, a mentality of now we will oppose or we will resist you being dumped into the workplace too soon may develop. And instead of working on real issues, the psychologists and the clients spend hours to no end working on how not to return to work and how to get an extension on it, and dealing with the anxiety created by the letter or by other form of communication. It's not actually about the information that the individual needs to return to work. It's more about how this information is communicated, and sometimes the absence of appropriate team approach and easing the client into the idea of returning to work and making this return to work somehow enticing in terms of graduate and return to work, making it look that it's something that actually can be done rather than something that's terrifying.
Very good. Another question that we got was, did your research address comorbidities, people living with pain that is not adequately addressed and evolves into other mental health issues?
Well, I did quite a bit of research on chronic pain independent of my research on work accommodations, and we know that comorbidity in chronic pain is very high. The number one comorbid condition with respect to chronic pain is depression, but anxiety is also frequent comorbidity. In addition, substance abuse can occur if people's pain is inappropriately controlled or managed, and there may be overuse or abuse of medication, particularly opioid dependency may form, and that may create a bigger problem than it tries to solve, because returning a client on opioids who has chronic pain, may have depression, and may have side effects of opioids, it becomes an almost impossible task.
That makes a lot of sense. Another one we had was someone who works with a group of clients who often quit work due to problems before they have actually discussed the problems with their employers, and usually due to stigma. Are there resources for these people to learn how to approach their employers with their mental health issues?
Well, again, in our book with Dr. Rogers, we have a couple chapters on the disclosure issue. University of Boston has done a lot of research on how to do the disclosures and how to encourage disclosure. So I would actually encourage you to look up the chapter on disclosure in that book. This ability to disclose varies from the diagnosis and also varies with perceived stigma coming from the employer.
All right, and then I have another one about occupational therapists, and wondering what your thoughts are on occupational therapists, what their role is within the return to work for people with mental health.
Thank you for this question. I really enjoy working with occupational therapists at a clinical level and also at a research level. Occupational therapists are much more hands-on than psychologists are, and they understand if they are trained, particularly if they are trained in mental health. And UBC Occupational Therapy, now it's called Occupational Science Department, has some excellent research going on in the area of mental health and occupational therapy. So as long as we are working with an occupational therapist who has a background and training in mental health, they are an excellent resource for employers and for clients. They also tend to have very good interpersonal skills, and they interact with teams well. There are some instances whereby they work under certain constraints from the insurer or other policy bearer, that they have this deadline that they're working towards that makes them anxious and makes the client anxious. Although these deadlines are important, but these deadlines should not be really based on arbitrary decisions, but rather on understanding of the clinical situation that can be best established through a team approach.
I want to thank everyone for being here, and thank you very much, Izabela, for your presentation. I think it was very informative.
You're very welcome. My pleasure.